Hello, my name is Austin Williams. I'm a PGY1 inpatient pharmacy resident at Prisma Health Midlands, and today I'll be presenting an evaluation of the diagnostic utility of metagenomic next-generation sequence testing for pathogen identification in infected hosts. I have no disclosures or conflicts of interest to announce, and I would like to thank Prisma Health Grant and Aid for providing funding for this research. The objectives of this presentation are to describe metagenomic sequencing, quantify the diagnostic utility of metagenomic next-generation testing in real-world practice, and to identify factors associated with high or low diagnostic utility. Next-generation sequencing is a method of DNA amplification that allows for billions of DNA fragments to be simultaneously sequenced. Unlike polymerase chain reaction, metagenomic sequencing, or shotgun sequencing, allows for detection of cell-free microbial DNA without the need for target primers. Karius Incorporated offers commercially available metagenomic next-generation sequence testing for microbiological pathogen identification with a proprietary algorithm for determining the significance level of pathogen detection from blood samples, and offer this directly to consumers as a means of microbiological diagnosis. The goal of the present study is to determine the overall clinical utility of metagenomic next-generation sequence testing and to identify factors that contribute to high or low utility. To do this, we conducted a retrospective cohort analysis of all tests ordered between June of 2018 to May of 2020. This evaluation included both adult and pediatric inpatients at a 641-bed academic medical institution and associated 174-bed freestanding children's hospital in Columbia, South Carolina. Individual tests were included for analysis if patients had a pre-test infectious diagnosis or clinical suspicion of infection at baseline, a test ordered for clinical diagnostic purposes, and were an inpatient at the time of test order. Tests were excluded from the analysis if the patient expired or admitted to hospice, or if the patient transferred to an outside hospital before receiving their test result. To determine clinical utility, 2 researchers conducted an independent blinded review of all tests meeting inclusion. Designation of high or low clinical utility was based on pre-specified criteria that were created a priori. Any discrepancies in determination of utility were escalated to a third blinded researcher for review. All tests meeting inclusion were divided into groups of either high or low diagnostic utility and were included in the statistical analysis. Here are the diagnostic utility criteria that were used to determine whether a test fell into either the high or low diagnostic utility categories. For the statistical analysis, baseline demographics and clinical variables were compared using chi-squared tests, Fisher's exact test, or student t-test. For the primary statistical analysis, a stepwise regression model was used to test for association with the outcome of high or low utility. Variables with a p-value of less than 0.25 in the univariate regression analysis were included in a multivariate regression model to test for independent association with clinical utility. During the study period, 96 tests were ordered for 82 individual patients. 16 tests were excluded for the reasons listed on the right-hand side of this chart. And after independent review and resolution of any discrepancies, 46 tests for 34 unique patients were included in the high diagnostic utility group, and 34 tests for 31 unique patients were included in the low diagnostic utility group. There were no observed differences in baseline characteristics between the 2 groups. The average patient age was 18 years old, with about half of the patients being pediatrics. There were also no differences in the overall presence or breakdown of indwelling hardware at baseline. And regarding severity of illness, the average Q-pit bacteremia score was 1 for both groups, with no difference in the number of patients with a Q-pit bacteremia score of greater than 2 at infection onset. There were also no differences at baseline in immunocompromising conditions or comorbidities, as shown in this table, though there was a trend towards significance for drug-induced immunocompromise. Shown is a breakdown of the criteria for high diagnostic utility. 58% of all tests during the study period were determined to be high diagnostic utility, and of these tests, 25% allowed for the initiation of appropriate antimicrobial therapy. 24% of these tests resulted in de-escalation, and 14% of tests resulted in treatment of a pathogen that failed to be identified by traditional diagnostics. The remaining 42% of tests were determined to be low diagnostic utility, with 70% of these tests resulting in no impact on antimicrobial treatment, and an additional 20% of these tests returning after traditional diagnostics returned positive. 36 out of 46 tests in the high utility group were positive compared to only 11 out of 34 tests in the low utility group, which was statistically significant. High utility tests were also more likely to have a consult with the Karius medical director. There were no differences in the number of hospital-acquired infections, antimicrobial use, or average antibiotic duration before test collection. Tests in the high diagnostic utility group returned on average 12 hours sooner from the time of test order than those in the low diagnostic utility group, but this was not statistically significant. Antibiotics changed after test result in 67.4% of high utility tests and only 11.8% of low utility tests, which was statistically significant. And this finding was primarily driven by de-escalation of antimicrobial therapy. While there were significantly more pathogens identified in the high utility group, the overall composition of pathogens identified did not differ significantly between the two cohorts. In the univariate regression analysis, a positive test, consult to Karius medical director, increase in QPIC bacteremia score from baseline, antimicrobial use at the time of test, and repeating a test all met the threshold for p-value of less than 0.25 and were included in the multivariate regression analysis for association with high diagnostic utility. A patient having diabetes at baseline met criteria to be included in the multivariate analysis for association with low diagnostic utility. In the multivariate regression analysis, a positive test and a consult to the Karius medical director were the only variables to maintain statistical association with high diagnostic utility, with an 11 and 3.6 times increased odds for resulting in high diagnostic utility, respectively. Additionally, diabetes remained statistically associated with low utility. To conclude, this study reports similar findings and rates of pathogen identification compared to previous trials evaluating a similar population. We demonstrate that a positive test is closely associated with high diagnostic utility and is more likely to be used to de-escalate antimicrobial regimens. We also demonstrate that a consultation with the Karius medical director is associated with high utility, particularly for amended tests. Additionally, the use of antibiotics did not appear to significantly influence utility. Overall, we conclude that tests, regardless of positive or negative results, and regardless of pretreatment with antibiotics, be accompanied by a consult to the Karius medical director. For my assessment question, true or false? Negative metagenomic tests are primarily being used to guide initiation of appropriate antimicrobials in the form of de-escalation. And that answer is false. Positive tests are primarily being used to guide de-escalation. I'd like to thank you for your attention, and at this time, I'll take any questions.